Okay. So yeah, once again, thank you for the invitation. The topic of my presentation today is about current and future perspectives in nuclear medicine dosimetry. And as it was said, I'm a physicist. I did my first degree in Rio, and then since then I've been in Europe and first in UK and then now in Switzerland. In terms of overview, what I'm going to present today, the first part is related to the nuclear medicine in terms of the timeline. So what has happened and where did we come from and where we are now. And then I'm going to jump and introduce the nuclear medicine dosimetry. The third part is concerning the clinical dosimetry workflow directly, and then the last part is regarding to the future perspectives. I will start with this nice saying from Albert Einstein. I think like is in order to understand the future, we need to look in the past. And that's why I thought that it would be nice to understand where nuclear medicine came from and how fast it has been evolved on the last decades. So this was a publication that we did not long ago, and we looked at the timeline for nuclear medicine itself. And if we look since the discovery of radioactivity, which was the end of the 1800s, and until the first use of radiation was barely like few years after. And then like you have the first part, I think, like when really nuclear medicine really evolved was when was the discovered and the invention of artificial created radionuclides, and you can see that like that came basically like straight after from the invention of the cyclotron. After that, of course, came the development of the Anger camera or the gamma camera, and the first commercial PET came straight after. So this was the really the beginning of the nuclear medicine, and then very interestingly, there was a publication from the International Atomic Agency about what's the future or what they think would be the future of the nuclear medicine, and actually. They were not very positive. They said that like although there was a lot of expansion happening with the innovative designs, they thought that like was a very challenging time for the nuclear medicine, and they thought like that these would dampen the further development of nuclear medicine. But they also highlighted that even though it was challenge these the nuclear medicine would face, it would be important to justify manpower and resources for the nuclear medicine itself. But I think like they were not aware of the future, and luckily for us working on nuclear medicine, that was not the case, because barely 20, roughly 20 years after the installation or the first commercial PET came the first SPECT-CT, and the first PET-CT came straight after, and pretty much that revolutionized the field of nuclear medicine. I put here just a very quickly description of what happened in Switzerland itself, and you can see that like on the last 2 decades, there was an increase of number of the devices, which meant that there was a huge increase as well of the modality and also increase of number of professionals working within nuclear medicine. But then the main question is that why do we do dosimetry itself? There is, I think, like important to mention that has different reasons why we do dosimetry. The first one is the philosophical point, where you have the treatment paradigm, because you do dosimetry because you want to spare the health tissues and you want to avoid unlimited toxicity. The second part of this treatment paradigm is that like you want to improve the efficacy, where you want to obtain better response for your treatment. And then overall, the treatment or the aim of this dosimetry is to treat a disease while we are preserving the normal organ functions. There is a second reason why we do dosimetry is the legal aspect of the dosimetry. I do apologize for being German, and the main part of the text is what is written and highlighted in red is that we need, especially for the therapeutical exposures of radiation, we need to understand individually what is happening with the doses in terms of the organ risks, and also in terms of and that these risks need to be minimized. The third part of, or the third reason why do we do dosimetry, of course, is related to the scientific aspect, is that more and more nowadays there are indications where, especially for the nuclear medicine, the impact of the dose that was delivered, there is a, a statistically significant impact on the how successful the treatment was. And for example, I highlighted these two publications, but actually there are pretty like many more. So let's start now. The first part is related to the dosimetry itself. So let's go in terms of the fundamentals of dosimetry. The first part is that in nuclear medicine, we are injecting radiation to the patient, we are giving radiation to the patient, and the first assumption is that this radiation is distributed within the body. Then it is based on the cellular functions and physiology, so that means that like that the how this radiation will be transported within the body and where it will be retained and where would be uh, the direction of these different exchanges is defined by the biodistribution and biokinetics of the tracer that was injected. The other part of which is important for the dosimetry is that is the definition that whenever the source is retained, it becomes a source of exposure, and all the other organs and tissues that are receiving radiation from these source become targets. And the dosimetry is often used for assessing the radiation-related risk, either deterministic or not, and is based on the absorbed dose to the individual organs, and that's why it's needed to be calculated. Very often this calculation is done using the formalism called MERD, and which was developed on the 1976. And the main idea is that you sum all the contributions that coming from the different sources to the different targets. Uh, but there is different levels of required um, dosimetry that is needed. And this is also always an important point to highlight. The first part is you have diagnostic procedures where often you try to understand what is the risk for given tracer that you're using, uh, either in order to reduce the risk, but also sometimes to compare with a subsequent new treatment that's coming. The other point is always is the use of try to understand like what's the best practice for reducing this exposure, and is often use the MERD phantom-based estimate. The second one, which is a second degree of complexity, is for therapies. There you are trying to understand what's the predicted response from the absorbed dose that has been delivered, and also to try to avoid the organ toxicities. There, you of course, you always aim to have more patient-specific estimation, and on the treatment plan, you tend to estimate the total activity given to an organ based on the absorbed dose limits. But the most important difference between these two methods is that on the diagnostic approach, you often tend to use a tabulated methodologies, and on the therapeutical aspect is patient-specific one is used. Uh, I mentioned before about the MEAD formalism, and this was introduced by the Medical Internal Radiation Dose Committee, and the idea is that like you estimate what's the absorbed dose for the patient based on the sum from all the activity that was absorbed within the patient, and the product from all the energy disintegration, and the fraction emitted by the source, and of course divided by the mass of the tissue or organ that you are evaluating. Now I'm going to explain the different aspects of this formula. So the first part is, as the name says, the accumulated activity, and is the estimation of how much activity is accumulated at given tissue or organ over whole duration of the treatment, or in the case of radiodiagnostic, in the life of the radioisotope. And once we have the accumulated activity, the effective half-life can be estimated by acquiring either multiple images or different other measuring techniques. The second part is the factor that's related to the energy per disintegration, and it provides information mostly about the different emissions during the decay of this radioisotope. It In this slide, you can see for example, like the contribution from photons and electrons and the total energy disintegration for iodine. And then the second term is the specific absorption fraction, and these define how penetrating the different emission is. As a first rule, often is for very penetrating radiation, for example, photons, these fraction will be anywhere between 0 and 1. And for electron alphans, this often is, because it's not very penetrating, is used that the radiation will be retained within the source. And the next step of this mere formalism was the simplification of this formalism with the introduction of the S value. There you have a conversion between the S value and these two parameters that was described before. And, and the idea is that with the energy disintegration, is because it is based on the physical characteristics of the nuclide, you can be predicted by different methods. And then this S value becomes the sum of all the different sources and the different isotopes. And this S value is known as the absorbed dose per unit of the accumulated activity for a given isotope and a given organ. For example, here I've included an example for the radionuclide technician 99M. And you can see for different rows, you have the target organs, and on the each column is the different source organs. Okay, but how is it is done in clinics? Of course, as I mentioned before, there is different levels of complexity that can be performed, and these will vary for what you're trying to achieve. So the first part, let's go for the source accumulated activity. There, the first assumption is that you are implying that your activity is absolute quantified. These I will mention a little bit more, but the main characteristic is that you are assuming that all the information that you have is already in activity units. This is often done for the whole patient, and should follow as well throughout of the time of the decay and also the biological decay. In clinics, this is often done by imaging the patient at different time points, and but can also be used with different pharmacokinetic models, or even very, very complex models. The second part of these of the dosimetry is the so-called S factor, where we try to understand what happened to the radiation, so how the radiation is transported through the material, and also the distance between the sources and the targets. And this can be done with a very simplistic models, but nowadays you go all the way to the geometries of the patients for become very patient specific. As I'm pretty sure, like most of you are aware, the level of the complexities of these models have been changed throughout of the time, and go from very, very simplistic representations to so-called mesh phantoms, which very realistic descriptions of the organs and internal structures. Nowadays, quite often is used is the actual image from the patient, and the dosimetry is done directly on the voxelized information, where you have specific the patient characteristics that you're trying to do the dosimetry for. Now, in order to understand if what has happened uh, what will be the case for the future, we need to understand, okay, what are the challenges that the dosimetry faces in the clinical setup. I think like there was a very, very nice presentation or a publication from Bardier and John Tanguy on the clinical oncology, and they highlighted this whole chain, which is the actual chain for the dosimetry. So first, you, as I mentioned before, you are always expecting to have uh, a calibrated image, so you always expected to have absolute information about what's the activity concentration at the different parts of the body. Then you apply some then you have to collect the data at different time points throughout of the treatment, or throughout uh, representable number of half-lives of the radioisotope. Then you have to understand what's the whole activity curve. After that, like you have to make sure that like that they are correctly registered and segmented the images between the different time points. Once you have all this information, you calculate what would be your time activity curve, and you can then make an assumption of or make estimation of the total absolute accumulated activity. Once you have that, it becomes the other part is the S value, which gives you the information about the absorbed dose. Just to make into the same graphical representation as I said before, is that first part you look into the what's happened in the biology part of the radiopharmaceutical, and then you try to understand what the implication of that different deposition of the activity throughout the different compartments inside of the body, and what's the so-called calculated is the absorbed dose. But then in terms of the quantification, the main question is that one megabecquerel or 1 becquerel measure in one device is the same as in the other device. So is can we really assume that like that the all devices and all the hospitals are capable to do absolute quantification? And the answer is Yain, or yes and no. Uh, this was a very nice publication from the Jonathan Trangia, where they try to understand if this quantification is held at least with not so old devices and throughout of Europe, where they created a 3D printed phantom of the kidneys and of the spleen, and they try to assess what's happening with the absolute quantification from these devices. The first part of the result was that they looked at the conversion factor that was applied by the different institutes. In this case, was 9 different hospitals, and overall, what they found was that yes, the conversion factor used by or calculated by the individual centers were quite well stable when they're using similar devices. And then the second part is, which is the interesting part, is that, okay, once you have the information about the conversion factor, can you estimate what is the uncertainty from your actual measurement? And what was interesting is that they found like uncertainties up to 15% between the measurements, and this was relative interesting to have a quantification of these uncertainties, because overall the um, the harmonization of the devices within Europe is quite well. There doesn't have like a huge amount of age difference between the devices. and you can expect that like whenever you have like even further heterogeneities, these will be even amplified, I would say. The second part of the workflow is concerning how many data points do you need to get and how you fit these data points in order to obtain your accumulated activity. I would point out again to this other very nice publication from the Sasha, and actually like she just got like a prize for this publication where she tried to understand what was the impact of the sampling done, and also which fitting model, either if you do a bio-exponential or a single exponential, or even five terms exponential into the fitting. What the main point that she found is that like that of course there is the there is a increase of your uncertainty based on the fitting that you use, and also based on the number of time points that you use, and these translates into errors of up to 60% based on the method that you use. Now this the third part is the define. Once you have your quantified image, and then once you have your activity, accumulated activity, now you need to calculate what's the absorbed dose. Think and another publication that I would like to point was this publication where they looked about what happened in terms of the contribution from different dose calculation methods into the final dosimetry. How they did that is that they simulate the dose deposition from different traces, different radioisotopes, with the idea that like different radioisotopes will have different emissions, and they use three main used methodologies for the absorb those calculations. One is the local energy deposition, the other one is the convolution method, and the third one is which they assume that was the gold standard, is the Monte Carlo. What was interesting is that they found is what we would expect, is that there is a high level of uncertainty whenever using the more simple approaches, which is this local energy deposition method, especially when there is a difference of densities between the materials, which was the case, for example, for the lungs. And quite interesting is that like that they found these differences about with a relative difference up to 200%, which is quite astonishing, especially like if you think that this convolution method is supposed to be quite good. Then once you have now the last part of your assessment is that you have your dose calculation method, you have your perfect fitted curve, and you have your perfect quantified image. Is you need to define what is the organ that you want to evaluate. And then I'll also point to this other group from the ENM, where they try to understand what's the uncertainties and the different sources of uncertainties within the dosimetry. This next point is this exactly about the definition of the volume, and you can see, especially like on these figures, that there are several sources of the volume uncertainty that can be applied. Sometimes is related to the inter and intra observer, i.e., whoever is drawing the lines. But there are also parameters that's related to the acquisition that you are applying. And to summarize all these source of uncertainties, you can see that it will go anywhere from close to 60% all the way to few percent for some of the parameters. And the same was found by this other group. And then when you translated this information about the how the degree of this information, and take into account the resolution that is capable for these devices, then you can separate what's the individual volume uncertainty based on your image, your preferred image device, or the device where you made your image. So then now we have understanding or an idea of what are the challenges and uncertainties for the clinical dosimetry workflow. So what are the future perspectives? What can be done in order to improve these challenges? The first one, I think, like, is in terms of the quantification, and I would say also our assumption in terms of these volume delineation is related to the device. One shift that has happened on the past, I would say, few years is that we are having more and more sensitive devices. There was a shift on the technology to use improved sensitivity and improved spatial resolution. And for example, like with one of these examples is these solid state detectors, where have been introduced clinically, and then by using these devices, you are able to have like a much better information about your energy deposition, and also because you have like a pixelated information, you have an improved spatial resolution as well. And by having a better energy resolution, you avoid the introduction of your uncertainties or noises or your impurities in on your quantification, because you have less information outside of the energy that you are interested in studying. And the example of these devices is I showed you before, the ones that is two still dual head devices, but this is also available nowadays in these whole body 3D SPECT devices. And not only changing the material that you have of the crystal itself, but also the electronics after, or i.e., how you're coupling your scintillator crystal with your electronics. These also allowed the improved information about the spatial resolution. I think, like, of course, there is also the before, in terms of the quantification, was the improvements related to the hardware part of your images. But there is, of course, always the improvements that, like, is an ongoing improvements with the reconstructions. I'm showing you this slide now, is actually was given by General Electric, and that they are showing that, like, how the different reconstruction algorithms for PET has been evolved, all the way now where we are using deep learning imaging reconstruction to try to improve these quantifications. And one of and you can see that, like, nowadays the reconstruction is taking care of the dead time and the geometry corrections and physical corrections with the scatter and attenuation, and also you have the partial volume correction. Nowadays the devices are not as influenced as before, because these, for example, like, is a curve from old devices, where you see that, like, your ability to recover information from very small lesions are always dampened, so that is always is moving throughout of the size of the voxel that you use. Nowadays, because the devices are more sensitive, they tend to use a much finer mesh of matrix sizes, and often you see this curve much more close to the ideal case. The second part after the quantification, as I mentioned before, is related to the sampling and fitting. How it is done in the dosimetry is, as I mentioned, is you collect the data at different time points, but this is very time consuming and cumbersome and very difficult to do, because you need to block the device for several minutes. You need to bring the patient back to the hospital. You need to no, and after that you still need to do all the registration and the corrections between the different time points. So there are different approaches that have been tested to try to overcome these limitations. One approach which I find very interesting and elegant is the use of surrogates for this multiple time point dosimetry. And this group in Rome, what they did was that they propose a wearable where you, alongside one of the imaging time points, the patient is collecting the information at, at a much longer duration of the treatment. And there is a very elegant way what they found, that what they did to deconvolute the information between the different organs. Another approach that is used very, very often is the so-called single time point dosimetry, where you make some approximation of what would be these effective half-life of the tracer. And you, by using this approximation, you can get like very close uncertainties, because this is often within few percent if you use the right acquisition time. This is, for example, like is a publication from Julia Bosch et al., where they showed that actually the uncertainties using this single time point can be, if you use the right time, within 20%, which is relatively good for the uncertainties, as I mentioned before. Because by using a single time point, you are avoiding other uncertainties, which is always welcome. And also the idea that like is if you have just one time point, you allow to make the dosimetry much easier. I think the main limitation of this approximation is, like I said, is that you have to do at the correct time point. For example, like this is a study that my PhD student was doing, and he used he performed this dosimetry similar to what was shown on by the Julia's paper, but up to 2 hours after the patient was injected, and you can see that like actually the uncertainties will go all the way to 100% and sometimes even higher.
Dr. Thiago,
So what he
five
proposed,
minutes. 5 minutes. We'll wrap it up.
okay. So what he proposed was to use artificial intelligence to generate this effective half-life, rather than doing approximation of this effective half-life. And what he did is he used his pre-therapy image information plus some patient characteristics, and he was able to predict what would be the effective half-life. And his results brought down these uncertainties, especially at the early time points, to a much more acceptable levels. There is, of course, some groups that were trying to use this pre-therapy imaging information to directly predict the absorbed dose. It works to a certain extent. I think like there is always going to be concerns about like trying to predict post-therapy from the pre-therapy, but there is more and more people having a look at that. In terms of the improvement of S factors, as you can imagine, there is also like a lot of work done in terms of using artificial intelligence to try to improve either or not improve, but like to predict the Monte Carlo, which would be the gold standard of the absorbed dose deposition, or sometimes even to improve these so-called convolution methods. And overall, they work very well. Of course, they have its challenges, because it is you are applying some more or less some filters within your images, and that means that like these at the moment is not done clinically, because it's not available as a commercial device. In terms of the Monte Carlo, there is also the possibility to apply corrections directly on the Monte Carlo itself. I would point to these publications from actually the guys from São Paulo, where they applied this variance reduction, and they found that by applying that, they were able to still maintain similar error uh, uh, of the absorbed dose calculation, but in terms of the time required for the calculation was much, much shorter, which the other point is that you can also use GPUs rather than use CPUs. And similar to that result, they found that, for example, like it was several orders of magnitude in terms of the calculations time that were required in compared to the standard Monte Carlo simulation. So the question is that, is dosimetry done clinically? And I think like was a very nice paper from by the European group called Siegfried, and which they try to understand how established and how used dosimetry is in the European centers, which often is thought to be the most advanced centers outside the US, of course, and but you can see that like which is not the case. Dosimetry is not really done clinically for all the patients. And quite often this is related to how cumbersome dosimetry can be and how specialized dosimetry can be, and which they highlighted as that, of course, there is always the further need for improving or making dosimetry easier, and also improving the training from people, and also availability for the tools. So I'll just conclude my presentation is that there is different levels of dosimetry, and base often is depend on what sort of complexities that you needed to implement. For the therapy specifically, there is a shift towards individualized treatment. And I think like the main aspects of the innovations in dosimetry is try to improve the workflow, and also the widespread implementation of dosimetry in clinics. So with that, I would like to thank you again for the invitation. And do you have any questions?
Thank you. So yes, are there questions? Several. If you could keep your questions and your answers brief, because we're coming up to almost to the next session. Okay, who's first?
Hi, Thiago, Lucas here. Thank you for your presentation. And we read the papers about the point of view, like external beam radiotherapy. Every patient is planned individually, and my question is, do you feel optimistic about all the efforts that's been done to reduce the workload to plan each patient individually in nuclear medicine? Are the community clinical medical physics community optimistic to in the future to implement individualized treatment plan in nuclear medicine?
Oh, thank you for the question. I think I think yes, I do feel optimistic, especially because now there is a kind of like a shift of, instead of calling nuclear medicine therapies, we are often calling now is molecular radiotherapy, because we want to make sure that people understand that it is a type of radiotherapy, and should have the same precautions and the same methodologies applied for external beam and molecular radiotherapy. And I think like a very nice, possibly like a shift in the perception is that nuclear medicine therapies often are associated with a very late stages of the treatment pathway for the patient, but now more and more they are coming closer to the first line of treatment. And these, I think, like was seen within Europe. We received like a comment about like end of last year from the European Medical Agency, which basically like is the Anvisa for Brazil, where they regulate all the pharmaceutical aspects of products. And there was highlighted the importance of the dosimetry already. So now we are hoping that like that, plus the work that is done by the medical physics societies, and like you said, with making easier to do the dosimetry clinically, hopefully that means that like more people and dosimetry will become a routine in the clinics.
Thank you. Thanks so much.
One more question, perhaps. Keep it short there, Thelma.
Yes. E aí, Thiago, de novo, bom dia. Tá frio aí, né?
Bom dia. Tá começando.
Tá começando. Obrigada pelo seu talking. Everything. The talk was really interesting. And yeah, we have this collaboration for the simulations that we've been done. And yesterday or day before, we talked a little bit about the production of scandium and terbium. Can you say a little bit about that? Are you using this in PET scan in the surface there, or is like only for research?
No, I think like in terms of like these new traces, they are more and more appearing. Now, for example, like in Switzerland, we have 1 or 2 clinical studies with the scandium and with the terbium, but unfortunately, like they're still a research project. They are not labeled product, which means that like that any hospital can use it. So, but I think like the results coming out are very interesting, and I think like these will help the introduction in the clinics of these novel isotopes.
Yes. Okay. Thank you.
Thank you. Thank you, Thiago. And I had similar questions about the uncertainties that you answered well. Thank you for a very comprehensive talk and your contribution to this conference.
No, thank you again for the invitation, and enjoy Belo Horizonte.
Thank you.